So I think anybody who does shoulder arthroplasty really quickly realizes as it comes to the glenoid component that really what it's all about is an accurate and reproducible execution of a well thought out preoperative plan. I would say though with some of Dr. Iannotti's recent work that our abilities to place our components in an accurate and reproducible way has really been called into question when using the traditional standard instrumentation. So you can see from this JBJS study recently that certainly with standard instrumentations, you can see our ability to place our components in an accurate way is really probably less than ideal at this point. So really utilization of planning software and guidance instrumentation, I think, and obviously Dr. Iannotti's group would agree, is really the future for placement of our components where we intend them to be. So I think we all have x-rays that probably are less than ideal, things that we would afterwards say that probably we did wrong during cases. And you can see these are 3 of my cases. I'm early on in my practice. I certainly probably am making more mistakes now than I will hopefully 10 years from now. But you can see, placement of base plates maybe higher than I would intend and resultant scapular notching, cranial tilt to the base plate, which certainly has some mechanical disadvantages, and perforation of the glenoid with cement extravasation and improper cement pressurization are all things that even in these 3 cases, which admittedly were pretty straightforward cases, I've done and really am not proud of. And I would say that the real issue is that I would say in more complex glenoids that we're probably even less accurate and don't appreciate our inaccuracy quite as much as we should. The implant community in the last probably 10 to 15 years has really responded to these complex glenoids by working more on changing the components, using things like metal back glenoids, ingrowth components, offset glenospheres, anchor peg designs, posterior augmented designs to deal with some of these complex glenoids. But I would say that no matter what, despite advances that you're seeing in some of these glenoid component designs, that really none of them can adequately compensate for an improperly positioned component. So the goal is to properly position things first and foremost. So this is really a unique opportunity for technology to intervene, and over the last year to year and a half, Arthrex has certainly made tremendous strides in this venue. So I'm going to demonstrate the VIP system through a case, I think a pretty demonstrative case here. So this is a 74-year-old female. She's had about 4 years of shoulder pain. She's had multiple injections, with the last one being about 3 months ago, and comes in with pretty severe pain. And her goals are moderate, mild to moderate as far as her activities. She wants to do light housework. She wants to sleep better, do some light overhead activities. Her motion is limited. It's mainly sort of a mechanical limitation. She can elevate to about 80 degrees. And her cuff was really difficult to assess on exam because of pain and limitation in motion. So these are her preoperative x-rays. You can see both on the left and the right pretty severe loss of the glenohumeral joint space. You can see on the axillary view an appreciable amount of retroversion. But when I critically evaluated these in the office, I felt like in this individual that her cuff is likely intact, and that an asymmetric ream, a partial version correction, or some form of posterior augmentation of the, with a standard total shoulder arthroplasty would be an appropriate operative plan. As with all of my total shoulder arthroplasty patients, I get CTs pretty much on everybody who's going to go to the operating room. And so, as you can see here, these are 2 representative axial cuts of her CT scan. And I evaluated this as I normally would. I looked at the CT scan and tried to think about in my mind's eye where I would place the glenoid component, how I would correct the version to get a predictable result. But I felt like an anatomic arthroplasty with a partial version correction was still a very viable alternative. But I will tell you the interesting thing is this is how I planned prior to VIP. I looked at the images and I tried to visualize where the implant will be placed and stop there. And so you feel like you're going in maybe a little bit blind, which is unfortunate. So here is the VIP system. So definitely a huge advantage over the way I was traditionally planning things. So this is a web-based system. You upload the CT onto the website. You enter some patient data here. And I would say one of the main advantages to the system that I feel is that it's a web-based system. I can access this from anywhere. which is definitely different than some of the other commercially available systems. So I think all of us as surgeons are strapped for time. We're pulling out iPads and laptops and things such as that to do work, and this really frees you up. It gives you a level of freedom in planning these cases and fitting it into your schedule so it's time efficient. And the last thing is that you don't have to download any software or add any software onto a desktop. The cost or expense of that is certainly not incurred to you or your institution. When you upload the CT scan, you have three options. You can do a plan only, a 3D model, or a 5D calibrator. So we're going to talk first about the plan only. So after you upload the CT scan, this is a representative image that you would get on the left here of your initial preoperative plan. And so you have the ability both on the two-dimensional CT here and the three-dimensional model here to place your glenoid component, whether it be a reverse or a total shoulder standard glenoid component, with the appropriate roll, the appropriate inclination, based on how things are fitting in the vault and how you'd like to position things. I think there's valuable information here about your sense of version, the measured inclination, and so it really gives you a lot of information. And so if you feel like you don't need any further sophisticated instruments, you just need to understand the anatomy a bit better, plan only is certainly a viable alternative to giving you better knowledge of what you're going to do in the operating room. For this case, this is actually that case that that I presented earlier. This individual had roughly 37 degrees of retroversion. And so if you need an added element of sophistication, an added element of accuracy other than just planning, you have the glenoid targeting device. And I know that Patrick spoke about this a minute ago, but this is a calibrated device, which is very importantly reusable and sterilizable, and we'll get to that in a second, but it has 5 feet on it here. And when you upload your CT, what gets spit back to you is a plan. It shows you on the software exactly where to place each one of these feet and the corresponding size and length of those feet that actually go on the targeting device. The great thing about this device, again, is it's sterilizable, it's reusable, and so the costs associated with having an instrument that allows you to very reproducibly and accurately position your central pin is not needed. It's a very, very powerful tool. Moving forward to our 3D model. So this was a case in this individual with a fairly significant degree of retroversion that I felt like the complexity of the glenoid really required utilization of a 3D model. And so this is actually this individual's 3D model. You can see a fair amount of retroversion here, a thin portion of the posterior glenoid here. This is intraoperative. These are sterilizable models that you have intraoperatively to utilize during the case to understand patient anatomy. As you expose the glenoid, you can palpate things on the model, go to the patient's shoulder, palpate various areas of the glenoid, and really get a sense of the patient's anatomy. Finally, I think probably the most powerful element of this whole system is the 5D calibrator device. And so this is actually, again, a reusable, sterilizable device which functions almost like a 3D model, where it allows you to position your glenoid targeting feet to an appropriate depth and give you the appropriate sizes of that. And again, it's something that is reusable, sterilizable, and from a cost perspective, truly an innovative addition to any PSI system. So this is the intraoperative. These are the intraoperative photos from this case. You can see a fairly retroverted glenoid. And I will say, again, I'm early on in my practice, but getting your mind to sort of understand what 37 degrees of retroversion is, you have a tendency to want to bring your pin fairly perpendicular to the glenoid, and you would have a tendency to perf anteriorly. So it took, even with the device in my hands, a little time to sort of position it appropriately. But once I did, it sort of locked immediately onto the front and back of the glenoid, and it had a fair amount of stability there, and it made you pretty confident in where you were placing it. This is demonstrating the pin placement. You can see with the 3D model here, the pin looks pretty spot on as far as its location, its version, its inclination. So it really seemed to reproduce my preoperative plan. There's the postoperative x-rays. So at 6.5 weeks, she came back, had an elevation of about 135 degrees, was very happy, had minimal pain. This is what I presume to be some form of type C glenoid that's 49 degrees retroverted. This was a case that probably before VIP, even now I have some anxiety about, but before VIP, I would say I had more anxiety. So this software really has given me an element of confidence going into the operating room that I truly understand the patient's anatomy prior to, to scrubbing in for a case.